Hi, and welcome to our program, Clinical Trials Update, What to Know in Myelofibrosis Care. My name is Ruth Fein, and I'm happy to be here to be your host today. I've lived with an MPN of one kind or another, that's a myeloproliferative neoplasm, for nearly 30 years. I was diagnosed with essential thrombocythemia in 1995, then polycythemia vera about 20 years later, finally myelofibrosis in 2018. So I've also lived with a number of complications, from dangerous blood clots and hemorrhages that put me in the ICU to debilitating headaches and bone pain and extreme fatigue. So the point is, I know myelofibrosis and MPNs. I also happen to be a health and science writer, and very fortunate to be in a clinical trial for the last 4 years with amazing results, eliminating my symptoms and significantly reducing my bone marrow. Joining us now is a top expert in MPNs, and certainly myelofibrosis specifically, Dr. Naveen Pemmaraju with MD Anderson in Houston. Dr. Pemmaraju, it's so nice to see you. Thanks for joining us and for being a part of this program. First, can you tell us more about yourself and what drew you to MPNs?
Hi, everyone. I'm Dr. Naveen Pemmaraju, professor of leukemia at MD Anderson in Houston, Texas. I serve as the executive director for cancer medicine for our cancer network at MD Anderson, as well as the director for our rare disease program, including blastic plasmacytoid and cell neoplasm. I am an expert in both the clinical trial research and patient care for patients with MPNs, including myelofibrosis, vera, ET, and mastocytosis.
It's always great to see you and to speak to you. You offer so much to this MPN community, and we really thank you. So we now have four JAK inhibitors, right? And one of them was just approved. Walk us through this. First of all, how does a JAK inhibitor work?
I think the JAK inhibitor class is a great place to start with MPNs and myelofibrosis. So the basic premise here is that myelofibrosis, or actually all MPN cells, we found in others that it signals through the specific pathway in the cells called JAK-STAT pathway. So take a regular cell, a blood cell, it already uses the JAK-STAT pathway for normal blood cell growth, differentiation, lifespan. Now take an MPN cell, and that pathway is hijacked, co-opted, used in a malignant way, and so those cells keep growing, and dividing. And so it's like a light switch that's turned on that doesn't go off. Interestingly, the JAK inhibitors, and this is a great place to mention this, are not JAK2 mutant specific inhibitors. So that's why they work in patients, whether they're JAK, MPL, CALR, or triple negative, no mutations. So JAK inhibitors are based on the principle that that pathway, JAK-STAT in the cells, are overactive, not working properly. The JAK inhibitors aim to block that overactivity or wrong activity or malignant activity and then restore normal growth. Now, in that, we know that ruxolitinib was the first ever approved JAK inhibitor now over a decade ago. And then since then, as you mentioned, there are now three JAK inhibitors that are US FDA approved: fedratinib in 2019, pacritinib in 2022, and then finally and most recently, momelotinib just within the last year. The four JAK inhibitors that I mentioned to you that are currently approved in the US have some interesting similarities and interesting differences, and I think it's worth mentioning. So, number one, the ruxolitinib, the first and longest in class, is a JAK1/JAK2 inhibitor. This drug was simply amazing in the original clinical trials, which were Comfort 1 and Comfort 2, led by Serge Verstovsek and Professor Claire Harrison. In those studies, we learned a few things about the ruxolitinib. One is that it works very quickly in relieving the symptom burden for our patients with MPN, so night sweats, these kind of symptoms. And it can shrink the spleen rather quickly as well, so quickly that the hallmark ended up being at week 24 by 6 months. Some side effects to look out for in this otherwise well-tolerated drug have been the development in some patients over time, opportunistic infections such as herpes zoster, so you have to watch out for that, shingles, as many of you have heard of. Weight gain, we're starting to appreciate that, particularly because the drug is approved in polycythemia vera, so not as cachectic in weight loss patients. And then finally, non-melanoma skin cancers, and I want to emphasize that one. So basal cell and squamous cell cancers of the skin, which are already kind of common in our patient population, older, et cetera. And so a lot of our patients end up seeing a dermatologist. Most of our patients don't necessarily discontinue for those side effects, but we need to be watching for them. Number two is the fedratinib. Fedratinib is a similar agent to the ruxolitinib, improves symptoms, decreases spleen, but it has a very notable toxicity or side effect, which garnered what's called an FDA black box warning. So a very serious potential side effect called encephalopathy. Some have seen it to be the Wernicke's encephalopathy, but on later analysis, not exactly the Wernicke's. Encephalopathy is a name for a syndrome that can cause problems with thinking, maybe even balance, and it can result from severe nutritional deficiencies. Furthermore, for the fedratinib, it appears that it displaces a very important vitamin B1 called thiamine. And so what we see is the linking of those. So all patients who are going to get treated with fedratinib should have a thiamine level checked, replacement of the thiamine, and then the encephalopathy can be related to that. Also, patients can have GI side effects with the fedratinib, so nausea, vomiting, diarrhea. So we really, really have to watch out for that, particularly in our older and more frail patients. The third JAK inhibitor is pacritinib, approved recently. This is an interesting agent. Again, all these are trying to hit the JAK-STAT pathway, but it hits other pathways outside of that, and maybe that's part of its benefits and potentially part of its toxicities. Again, it helps to shrink down the spleen, improve the symptom burden of our patients. But the unique thing here with the pacritinib is for several years it was being watched for the development of cardiac and or bleeding signals. Now, myself and others have done a lot of the evaluation and analysis, including post-approval. We're not seeing a high signal for that, but that's something you have to be aware of if the patient is on a blood thinner, having chest pain, having a heart surgery. So you need to watch out for this bleeding and or cardiac signal. And then finally, the momelotinib, that's the most recent JAK inhibitor, the fourth one of four. Again, not only it showed improvement in the spleen and symptoms, but what's interesting here, and the pacritinib also is showing this as well, is potentially in many patients having an improvement in the anemia. Now, that's important. The ruxolitinib and potentially the fedratinib actually don't necessarily do that, and in some cases can make it transiently worse. So the momelotinib having the signal, ACVR1 inhibition, and the pacritinib also showing that as well, unleashes a new era for our patients of potentially JAK inhibitors having beneficial side effects, if you will. So improvement of anemia, potentially improvement of thrombocythemia. You do have to watch out for GI side effects with these last three. So fedratinib, pacritinib, even the momelotinib as well. And in the earlier studies of momelotinib, there was a signal for peripheral neuropathy. So I just want to put those forward as an overview. Obviously, there's some subtleties and differences if one reads further.
The loaded question then is this: how do you know which JAK inhibitor might or might not work and which one to try first? How is the decision made?
Yeah, the decision for JAK inhibitor switching and changing is not yet a scientific one. We're not there yet. I think I envision at some point that we'll have a decision tree, maybe even like our colleagues in CML. But right now, there's no molecular test. There's no sine qua non answer, if you will. And so it is art of medicine. It is clinical decision making. Now, there are some factors if one looks up in the NCCN and other guidelines. One is, for example, platelet count. So the ruxolitinib and fedratinib should be given in patients who have a certain sufficient amount of platelets. And that's actually where the pacritinib was able to get its approval. It's specifically approved in the frontline setting, platelets less than 50, for example. Now, the NCCN guidelines and other groups say that once you use the pacritinib in later lines, maybe you don't have to pay attention to platelet as much, but that's obviously for debate. So one thing is platelet count. Another factor is this GI signal, as I mentioned. If you have someone who has a known encephalopathy syndrome, Wernicke's, thiamine deficiency, then the fedratinib is not going to be one that you would choose. And then finally, I think you have to look at some of these subtle side effects that we mentioned earlier. Again, GI and neuropathy and some of these others that help you to choose. But the bottom line is there's not a single molecular test right now. It's basically clinical factors and art of medicine decision making.
So it's possible that somebody could start on one JAK inhibitor and at some point switch to another. Is that an issue if you change?
Yeah, great. This is a great important point, that of switching the JAK inhibitor and what are the indications. So there are several buckets here, actually. Bucket number one is clear disease progression in terms of the spleen. So if you have a patient who's been on, say, ruxolitinib or a JAK inhibitor for a sufficient amount of time, 3, 6 months, whatever you want to call it, and then you have a spleen that was shrunk and now it's starting to rise again, that could be considered disease progression and indication to switch. Number two is rising or worsening MPN symptom burden to the point where the patient's quality of life is affected. Number three is blast count, peripheral blasts or bone marrow blasts going up. And then finally, a fourth one is the progression of the disease to outright higher level of disease, what we call accelerator blast phase. So those are some buckets there. I would also say the development of these clinical factors, such as the platelet count, may matter. If you have a patient who's on Rux, for example, and you consistently have platelets below 50, then that's an indication to switch, for example, to the pacritinib. If you have a patient who has the anemia in MF, you may be thinking about momelotinib. So these are some of the reasons to think about switching. But again, I like this conversation very much because it highlights that there's not a molecular test or a definitive, this is when to switch. The implication of switching can have financial cost repercussions, new toxicities when a patient was otherwise doing, quote, okay, could have problems with access to the drug. And then finally, it could also uncover random or idiosyncratic side effects that is maybe specific to only that patient that wasn't seen on the studies. Finally, you have a question of withdrawal syndrome, overlap. So these are some of the things I think we'll all work out together over the coming years as we have these JAK inhibitors in the clinic.
We're seeing some really exciting updates as far as combination therapies. So let's talk about that for a minute. Talk about clinical trials, if you would, and let's start with selinexor plus JAK inhibitor, and then move on to some of the other combinations.
So the most important meeting, international meeting for all blood doctors and blood pathologists is the ASH meeting, which is the Annual Society of Hematology meeting, which is actually hosted in the United States and rotates around 4 to 5 cities. But it's the biggest meeting of the year. Anywhere from 25 to 30,000 people attend every year. And this is where most of the cutting edge research is shown. It's always in December of every year. Yeah, at ASH this year, our colleague, Dr. Sri Tantravati from Utah, presented the first public data of frontline combination, updated, I should say, of the selinexor with ruxolitinib. So this is untreated patients with myelofibrosis, intermediate to high risk, who then were given the combination rather than ruxolitinib, which would be considered the standard, or JAK inhibitor. And although it was early on, only a few patients, very surprisingly, very amazingly, the group showed that there's a high rate of activity in both spleens being reduced as well as symptom burden being increased. Now, this is early on preliminary data, but it was so encouraging that they're now moving into a phase 3 randomized global study, the combination selinexor ruxolitinib, so the XPO1 inhibitor plus JAK inhibitor versus JAK inhibitor alone. And so those data will be eagerly awaited.
What about navitoclax, a BCL inhibitor, and that in combination with a JAK inhibitor?
Yes, and so a second combination is that of the BCL-XL inhibitor navitoclax with ruxolitinib, which I actually personally presented as an oral presentation at ASH on behalf of my colleagues. This is also, if I may say, a fascinating study. So 252 patients globally enrolled, randomized double-blind placebo-controlled study, ruxolitinib plus navitoclax, which of note is not yet approved for any indication, navitoclax, versus ruxolitinib alone. And again, intermediate to high risk patients, mostly intermediate 2, 80% plus intermediate 2. What we found is a very outstanding rate, 60 plus percent of the patients in the combination arm having an SVR 35 at week 24, so spleen volume reduction 35% or more at week 24, versus only 30 plus percent in the control arm, which was ruxolitinib alone. The waterfall plot showed that basically the vast majority, almost all patients, really benefited from the combination. But in an important twist, in terms of statistical analysis, the primary endpoint was met, highly statistically significant, what I just told you, the spleen, but the symptom burden difference was not yet found to be statistically significant. Both groups had reductions, so there was numerical reduction of the symptoms in both the combination and the Rux, but there was not a statistical difference. So the study's ongoing for collecting for maturity, overall survival, duration. So this was a preliminary presentation at 15 months follow-up. So we'll stay tuned to see how it gets updated over the next congresses. But suffice it to say, this combination showed fantastic activity, great safety. You do have to watch out for thrombocythemia, which is low platelets, and you have to watch out for that signal very closely.
Another combination being investigated is the use of a shot called Luspatercept, right, to boost hemoglobin or fight anemia. And that also is being used with ruxolitinib. Can you tell us more about that one?
Yes, so another combination or another novel drug is that of luspatercept. Luspatercept is a fascinating molecule. It's already FDA approved in the MDS or myelodysplastic syndrome setting. Some folks will be familiar with that term. Um, but in our myelofibrosis in the MPN setting, we think it has a similar activity, which is to improve the hemoglobin, improve the anemia, this sort of urgent unmet medical need. And the initial studies have shown positive data, which is either by itself, so the luspatercept injection by itself, usually given every 3 weeks, or I think as importantly in combination with JAK inhibitor ruxolitinib. So those studies are ongoing, and we do eagerly expect and await those results in the coming 1 to 2 years.
We've also had the Manifest trial, which is a trial that I happen to have been on for the last 4 years. And that's a different drug. That's pelabresib. So maybe you could talk about that combination and tell us what you know about that and what you think the potential is.
So another exciting combination that was presented this year at ASH was that of the Manifest 2, which is ruxolitinib plus a new agent pelabresib, not yet FDA approved for any indication, which is a bromodomain or BET inhibitor. And this encouraging data set was presented by our colleague, Dr. Rajit Rampal from Sloan Kettering. In this very large study, it's actually the second largest study ever conducted in this myelofibrosis frontline space, 430 patients. They also randomized, very similar design to the navitoclax data set I mentioned earlier, ruxolitinib pelabresib versus ruxolitinib alone in the control, mostly intermediate 1 to intermediate 2 patients, so slightly different population. They showed a very similar profile. Highly statistically significant primary endpoint met, which is the SVR35 at week 24. So again, this sort of 60 plus percent versus 30 plus percent. But again, the symptoms in all comers, so in all the 430 patients, again, although showing numerical decrease in both groups, did not quite meet statistical significance. Now, when the group looked back at certain subsets, including in the intermediate 1 patients and others, it did appear that there was a benefit there in terms of both the spleen and the symptoms. Now, this supposition is the same as what I told you earlier with navitoclax. These two are the first ever in our field resulted phase 3 global double-blind placebo-controlled frontline, upfront untreated myelofibrosis patients with a novel combination. In this case, pelabresib and navitoclax, neither of which are FDA approved for any indication. So brand new drugs. I would say my editorial comment is super exciting for the field that we even did it. Both of these studies were largely conducted during the pandemic time, both of them international studies involving lots of patients, lots of investigators. And by the way, the primary endpoint was met for both of them, the SVR35 at week 24, resoundingly met, doubling basically. But the question will be, right, is the symptoms were not quite met in either study in terms of p-value, statistical significance. And so the question that is asked is threefold. One is, what is the utility of following the symptom burden scale in combination studies, something that was designed 15 years ago for JAK inhibitor single agent? Two, do we actually expect a combination to improve symptoms over, say, ruxolitinib alone? Or because you're introducing a second drug, you're going to introduce new toxicity? And then three, I would like to call for on behalf of my colleagues, maybe it's time to reassess, reevaluate in a healthy way what are the endpoints for our patients with myelofibrosis. I would put forward perhaps in addition to reducing spleen size and improving symptoms, we should be factoring in overall survival, progression-free survival, event-free survival, bridging to stem cell transplant. And I think that this is the time to talk about it because these combination studies are difficult, if not impossible to judge based on the Comfort 1 and 2 study from a decade and a half ago.
Let's go beyond JAK inhibitors. There's other drugs that are being studied, right? Could you help us understand some other approaches?
There's really an exciting, I would call it an alphabet soup of clinical trials and drug molecules out there. And I think it's exciting for our patients to know that, first of all, there are people around the world who do care about our diseases of MPNs, pharmaceutical companies, other stakeholders. So it's good to know that despite COVID time, whatever you want to say, we have a lot of innovation. The second aspect of it is we're adding a new trial once a week. So it's almost impossible to keep up, but I do want to give the viewers some sampling of what's going on. And then one can always read about these later. One is what you mentioned, which is the imetelstat. Imetelstat is very important for everyone to know. This is a first-in-class telomerase inhibitor. Telomere, some people have heard of these. These are the little ends on the ends of chromosomes that help to determine aging and possibly even cancer biology. So this telomerase inhibitor, imetelstat, is now in an ongoing phase 3 trial. That's the theme, I guess, of our discussion here, which is in the second line setting and beyond. So the imetelstat against BAT, best available therapy. And I praise this trial because it's the first, and to my knowledge, only phase 3 trial that has overall survival as its primary endpoint. So that will give us a readout, hopefully in the next year or two, on that. So imetelstat, let's keep our eye on it. Again, a lot of these drugs are in development in other diseases such as MDS. The second drug you mentioned is MDM2 inhibitors. MDM2 inhibitors have gotten a lot of press in our field in all the MPNs. So polycythemia vera, myelofibrosis, maybe even in post-MPN AML. This is a key pathway that has to do with guarding the cell, P53, TP53. And I think the concept here is that it's an oral drug. It has been studied before. As a class of drugs, maybe some GI side effects to watch out for, but in the later trials that we've seen, the groups have figured out a way to address that with either dosing schedule or dosing frequency. Really excited to see where that area goes. Right now, the lead trials are MDM2 inhibitors with ruxolitinib as an add-on approach or a suboptimal approach. So that means you're already on your JAK inhibitor. You have an okay response, not a great one, not quite ready to come off of it, and then you add in the MDM2 inhibitor. So those studies are active, ongoing, and I think we'll be excited to see those results.
And what if someone's myelofibrosis isn't driven by a JAK mutation, but a different mutation? Is there a different approach? And of course, some people we've been hearing more about a cancer vaccine related to CALR. So maybe you could walk us through both of those things together.
Excellent. So two-part answer for the question of molecular mutation targeting in MPNs. One is historically and in the clinic right now, there is not a difference at the moment. So the good thing about MF, myelofibrosis, is whether you're JAK, CALR, MIPL, or triple negative, you respond to these JAK inhibitors and the novel agents alike. That's kind of a quirky, interesting thing, suggesting that there's a common pathway. But for the future, yes. Already in the clinic, this year of 2024, we expect the new era to begin, which is exactly what you're asking, which is for the first time to have mutant-specific approaches for both JAK2 and CALR. So I expect that we'll see multiple different drugs targeting mutant JAK2 specifically. Now, the hypothesis is, could that be better and more specific than targeting the whole pathway? That's the hypothesis. Let's see. So you'll see phase 1 trials there. And then also, as you asked for CALR, CALR turns out to be a really good target, especially for immune therapy targeting. That's only new science in the last 5 years. And so, as you mentioned, there's vaccine approaches either by themselves or with other immune drugs such as ipilimumab. There's an exciting bispecific molecule, which is mutant CALR by CD3 bispecific antibody that myself and others will be working on. There's also going to be approaches, other ways to target CALR. So I think that the Insight team presented data at the ASH plenary session 2 years ago on a monoclonal antibody for CALR. So you have multiple different ways of targeting for the very first time mutant-specific approaches. But let me highlight for our viewers, these are phase 1 clinical trials that are just starting this year. So they're backed by animal, preclinical, before you get to patient data. Now we need to see how it does in the initial trials.
Dr. Pemmaraju, you mentioned that many people suffer from anemia when hemoglobin is low. We know they can feel extremely fatigued, so much that it interferes with their quality of life, which I know from personal experience, unfortunately. With what you've described, do you feel like we're getting better tools to fight anemia and hopefully avoid people needing more frequent transfusions?
Yes, for the first real time, I'm seeing the sustained improvement in the anemia of MPN, specifically myelofibrosis. This is for the very first time. You've got basically 3 different buckets or categories trying to address this for our patients, and it's simply exciting. Number one is the JAK inhibitors themselves, as we mentioned earlier. The first initial ones did not improve, may actually have worsened the anemia, at least transiently in some patients. So now you see these second and third generation JAK inhibitors actually improving the anemia, and possibly we even know the biology through inhibition of ACVR1. So that's exciting. That's category 1. Category 2, is the additional agent, such as the Luspatercept that you guys mentioned earlier. So you can add on an agent that works outside of the JAK inhibitor that aims to stimulate the hemoglobin, improve the anemia. And then third is these novel agents. When you look closely at the navitoclax data set, the pelabresib data set, at least in those two particular instances, yes, you have some people who get anemia as a toxicity, but you also have some patients who have anemia improvement with the combination, maybe more and better than you expected with ruxolitinib alone. So at least those three approaches that we're already seeing in the clinic in phase 1, 2, 3 clinical trials. But I really love what we're talking about here. Out of all of these academic theoretical things, a lot of times what our patients are suffering with at home, what they tell me in the clinic, is the anemia. When the hemoglobin gets down below 7, 6, 5, 4, sometimes not even compatible with life, much less quality of life. And so anything we can do to reduce the burden of transfusions, missed appointments, missed life events, I think that's going to be a big breakthrough, and I'm starting to see that.
So typically, a doctor will tell a patient that the only cure for myelofibrosis is having a stem cell transplant. With these new medical therapies, my question is always the same. Do you see a changing role for transplants?
The role of stem cell transplant in myelofibrosis is one of great importance still. So while I'm personally excited for all of these drugs in development, the ones I mentioned to you here and so many more that we didn't have a chance to talk about, it's important to say two things out loud. One, none of these has been shown to create a long-term cure in and of themselves for myelofibrosis. And two, if transplant is available and indicated, it is the only curative approach for MF. Now, having said that, the realistic problem, I guess I should say, about allo transplant is that it's not available for everyone. Your comorbidities, how frail versus how fit you are, matching, the infection rate, the mortality rate from it. As we get older, it may be tougher at some centers and some folks to do it. So there are some real limitations. I think the other problem is that out of all of our patients, most of them are not going, the vast majority are not going to transplant. So improvements are being made with transplant every day. Haplo transplant, which is a half match, is becoming more of a standard. So that gives the donor pool exponentially more options. Trying to reduce what we call graft versus host disease, which are complications after the transplant with medicines, are kind of revolutionizing the field. Transplant, as I've traveled all over the world, India, Europe, Asia, Middle East, Africa, people are able to do stem cell transplants in economically diverse situations. And interestingly, even though cost effectiveness is an issue, because the transplant procedure itself can be highly expensive, in some locales, the calculations are actually that if you can do a transplant as a quote unquote one stop on the journey and potentially cure the disease, that maybe you can lead to improvement in socioeconomic status overall. So there's some really cool, important things happening. But I think it's an important point that even with all the excitement of these medicines and medicine combos, we're still not yet at the point where we're talking about cure. And so if you have the availability and indication for transplant, you have to pursue that consideration.
Let's put all this together. For those of us living with myelofibrosis, what do you want to leave us?
Well, this discussion was very exciting because it leaves me with even more hope than when I started out the day. So I would leave our patients, caregivers, family members, advocates, and stakeholders with a message of hope and positivity. It's not a blind hope and positivity. It's not one based on hunches or ideas. It's one based on data. The last 3 years in particular, I would call it, and I do not use this phrase lightly, a new golden era for research for the MPNs, specifically including myelofibrosis. I think 4 areas to highlight and to be very excited for our patients and families, and you've heard most of them here. One is the development of new JAK inhibitors. We mentioned the 4 that are already approved in the US, so let's get them available all over the world, and then there are several more in clinical development. 2 is the JAK inhibitor plus combinations. Very exciting data from ASH, as I mentioned to you here. So let's see the new combinations, maturing data for the navitoclax, pelabresib, and selinexor. Yet a third area of excitement and hope is that of the anemia improving agents, which we talked about here. And then finally, I would say a fourth area of hope is the delineation, description, demonstration of brand new pathways, molecular pathways inside the cells that were never known before. So new basic science insights, new ways of approaching. We mentioned earlier immune therapy approaches, potentially this CALR mutation, for example. So super exciting in that we have brand new approaches that we didn't have 3, 4 years ago. Lots of data, lots of science. So my word I would end on is hope.
Dr. Pemmaraju, thanks so much for being with us today. You're always a pleasure to talk to and so informative to our guests. This was sort of an A to Z discussion about myelofibrosis, and we really appreciate your time.
Thank you so much for having me. I also found this to be a very thought provoking and stimulating discussion.